Today topic is congenital heart disease. We can classify congenital heart diseases into acyanotic and cyanotic. Acyanotic means congenital heart diseases which are without cyanosis, and cyanotic heart diseases are the diseases which are present. Their presentation is with cyanosis. Cyanosis is blue discoloration of the skin. In case of acyanotic, we can again divide the diseases into two types, left to right shunt, and that includes ventricular septal defect, patent ductus arteriosus, and atrial septal defect. In case of cyanotic heart diseases, we will discuss the two main types, tetralogy of Fallot and transposition of the great vessels. We briefly discuss the steno heart defects which are due to stenosis, that includes pulmonary stenosis, aortic stenosis, and coarctation of aorta. Coming to the pathophysiology of congenital heart disorders, the main pathophysiology or the cause is the genetic defects. Then comes the environmental factors and then viral infections. In environmental factors, there is a uh, gestational diabetes and other viral infections that may cause congenital heart disorders. We will discuss a little bit in briefly genetic mutation, which is the most important and known cause for the congenital heart disorder. There are known genetic disorders or genetic mutation or the deletion of the chromosomes that may lead to congenital heart defects, and there are unknown mutations which are not yet identified that may cause congenital heart defects. In main known causes, there is a sporadic mutation which may be single gene mutation which involve the signal pathways or transcription factor, so for the cardiac development, and the best example is GATA4 mutation. Then comes the deletion of the chromosomes of the 22q11.2 affect third and fourth pharyngeal pouches. If you remember your embryology, these third and fourth pharyngeal pouches are responsible for heart development, and so this deletion of the chromosomes may lead to defect in heart development and congenital heart disorders. The best example is DiGeorge syndrome. Another most common cause for congenital heart defect is trisomy 21, which lead to Down syndrome. There are unknown mutations which may cause these heart defects. Now we will come to the acyanotic heart diseases. In acyanotic heart diseases, there is a left to right shunt. The blood from the left side shunt towards the right side of the heart. As you know from your physiology, there is a right side of the heart and the left side of the heart. Right side comprises of right atrium receiving blood systemic circulation, pushing to the right atrium, right ventricle. From right ventricle, blood goes to the pulmonary circulation for oxygenation, and then coming back to the left atrium, left side, and then left atrium to the left ventricle, and from left ventricle going to the systemic circulation. But in these cases, left to right shunt, the blood is diverted from left side to the right side, and there is increased volume overload on right side of the heart. Left to right shunt lesions or heart defects include atrial septal defect, ventricular septal atrial septal defect, ventricular septal defect, and patent ductus arteriosus. The main clinical feature is due to there's a hemodynamic sequelae. There is a failure to thrive because of hypoxia, retarded development, infective endocarditis. Because of hypoxia, there is endocarditis, and that lead to pulmonary. Left to right shunt causes pulmonary volume overload. If prolonged and if remain it prolonged, volume overload, it may lead to increased vascular resistance, leading to pulmonary hypertension. Then there's a altered high hemodynamic usually causes chamber dilatation, as it is like more and more pulmonary volume overload, pulmonary hypertension. Then there is a back pressure on the left ventricle that may cause the chamber dilatation and hypertrophy. Then there are some at the end stage of the disease, there is a sign and symptoms due to hypertrophy, failure, or dilatation, or pulmonary hypertension. Pulmonary hypertension is the end stage of disease. Cyanotic heart diseases are right to left shunt. The blood which is on right side, instead of going to the pulmonary circulation for oxygenation, it is diverted to left side systemic circulation. So as it is there is no oxygenation process in the pulmonary vasculature, there is a cyanosis. Cyanosis, I have told you, it's a bluish discoloration of the skin and mucosal membranes. The main defect which include cyanotic heart diseases are tetralogy of the Fallot and transposition of the great vessel. We will see in detail in as we move to the next few slides. We will discuss in detail these disorders. The main feature is of the right to left shunt is bypassing of the lung, and it is tissue hypoxia, venous emboli to enter into systemic circulation called the paradoxical emboli. Secondary finding in case of right to left shunt is long-standing cyanotic heart diseases. It lead to the finger clubbing, finger of the hand and foot, and polycythemia. Why polycythemia? Because blood is responsible to deliver oxygen to the tissue. When there is tissue hypoxia for any reason, there is a message going to the bone marrow, there is a hypoxia in the body. Due to that hypoxia signal, the bone marrow is trying to make more and more red cell to compensate that hypoxia. Due to that reason, there is a development of polycythemia. Again, we come to the slide. We have briefly discuss or see there is a left to right shunt and right to left shunt. Left to right shunt include ventricular septal defect, atrial septal defect, and patent ductus arteriosus. Then there is a outflow obstruction which include pulmonary stenosis, aortic stenosis, and coarctation of aorta. Let's discuss each defect into detail. Atrial septal defect. Atrial septum, as you know from your embryology, there are two atria, right atrium and left atrium, and there is during the development there is a septum developed between two atrium which is separating the two atrium. But during the embryonic life, there is a shunting of the blood from right atrium to the left atrium, and as the lungs are not functioning, so this opening is open, is patent during embryology, but just after birth this septum is closed due to septum secundum. But somehow it is after birth it is not closed, and it remain patent, and it will lead to atrial septal defect. It is the opening in the atrial septum permitting free communication of the blood between atria, and it constitute about 10% of all congenital heart disorders. It could be septum secundum of the atrial septal defect or at the fossa valis, and it is the most common atrial septal defect. It could be the primum, lower in position, in the form of atrial septal ventricular defect and mitral valve cleft. It could be sinus venosus, and it is also a least common. The most common variety is the secundum, and it is this one here. The most common defect is septum secundum, which lead to atrial septal defect. Here is the atrial septal defect, and it could be here. ostium secundum. It is the picture that can elaborate the atrial septal defect. Clinical symptoms, it's rarely present with the sign and symptoms of congestive heart failure or other cardiovascular symptom. Most patients are asymptomatic but may have easy fatigability and growth failure. Cyanosis may not occur unless there is a pulmonary hypertension. When in late cases, when the pulmonary hypertension develops, then it may cause cyanosis, but cyanosis is not the early symptom or sign. Here comes the ventricular septal defect, which is again a left to right shunt. It is an abnormal opening in the ventricular septum, allows free communication between the right and left ventricle. It accounts for 42%, and it is the most common congenital heart disorder, 42% of the congenital heart defects. And you can see here in this picture, previously in atrial septal defect, there is a communication between two atria. Here there is a communication between two ventricle. This is the blood which is oxygenated from left side of the heart is mixing with the blood or communicate due to this communication to the right side. As there is a normal oxygenation process is going on, it is just the mixing. So patient is not cyanotic. As I told you, these are the acyanotic heart defects. Again, there is a different types of ventricular septal defect. As you know, again from your embryology, knowledge of embryology, the ventricular septum has got two parts, the membranous part and the muscular part. So same way the septal defect could be in the membranous part, or it could be in the muscular part. There are four types depending upon the location. There is a membranous. This is the most common. Infundibular involves the right ventricular outflow tract, and the muscular can be single or multiple small holes, and at the inlet of ventricular septal defect, the most almost always involves atrioventricular valvular abnormalities. If the ventricular septal defect is small to moderate, are usually asymptomatic, and the 50% close spontaneously by the age of 2 years. Moderate and large ventricular septal defect almost always symptomatic, and they may require surgical repair at some point in time. In case of small ventricular septal defect, no surgical intervention is required. There is some physical restriction, reassurance, and there is a periodic follow-up and endocarditis prophylaxis for the endocarditis. Symptomatic ventricular septal defect, there is a medical treatment which may reduce the afterload, and the patient may need diuretics. But there is a surgical treatment which requires indication. I will not discuss here because we are discussing the pathology side of ventricular septal defect. Then comes the last type of acyanotic left to right shunt, patent ductus arteriosus. Persistence of normal fetal vessels that join pulmonary artery to the aorta. It's again your embryology knowledge. There is a communication during the fetal life. There is a communication between pulmonary artery and the aorta. Normally it closes in the first week of excuse me. Normally this communication closes in the first week of life. But in case of patent ductus arteriosus, it will not close after the first week, and it remain patent, and it will cause the shunt of the blood from left side to the right side. It accounts for 10% of all congenital heart defects, and is seen in 10% of other congenital heart lesions, and can often play a critical role in some lesions. In case of male and female are twice. This defect is more common in female, and male-female ratio is 2:1. It is also often associated with other disorder like coarctation and ventricular septal defect. Torch infection, which is associated with patent ductus arteriosus, is just a food for thought. answer, I will move forward and you will check. The hemodynamic issues that are associated with pulmonary stenosis are heart defect. Most cases are isolated lesion. They are not the combination of other congenital heart disorders. The pulmonary stenosis occur as a isolated lesion. Maybe it could be bicuspid or fusion of two or more leaflets of the pulmonary valve. What syndrome is associated with pulmonary stenosis? It's a Noonan syndrome. Hemodynamic pathophysiology, right ventricular pressure hypertrophy. As I am in different slides, I am again and again telling you, if there is a outflow is obstructed, so there is increased pressure in this chamber. It try to push out the blood into the pulmonary vessel. As the outflow is obstructed, the right ventricular pressure and the volume overload is increased. It has to like exert more force, so it is hypertrophied. Right ventricular pressure hypertrophy, right ventricular failure, right ventricular pressure may be more than systemic pressure, post stenotic dilatation of the pulmonary artery. Then if there is a severe stenosis, then the right to left shunt through cyanosis. And there is a, in the end stage, it may end up as cyanosis. Cyanosis is indicative of critical pulmonary stenosis. Here comes the aortic stenosis is an obstruction of the outflow from the left ventricle at or near the aortic valve that causes a systolic pressure gradient of more than 10 millimeter Hg, and again it accounts for 7% of all congenital heart disorders. Aortic stenosis could be of three types. Valvular, which is most common, there is a stenosis at the site of the valve. It could be subvalvular, subaortic, involves the left outflow tract, and it could be supravalvular, involves the ascending aorta, and it is the least common variety. Which syndrome is associated with supravalvular stenosis? It's a Williams syndrome, and it is due to the chromosome 7 deletion. Hemodynamic abnormalities, there is a pressure hypertrophy of left ventricle. As you know, as you can see, there's a stenosis of the aorta. Again, as I told you about when I was discussing the pulmonary artery stenosis, left ventricular has to exert more pressure to push out the blood. So there is a left ventricular hypertrophy. In case of mild aortic stenosis, the left ventricular pressure is 0 to 25 millimeter Hg. In moderate, there is a 25 to 50 millimeter Hg pressure of the left ventricular. In severe cases, it is 50 to 75. And it is critical aortic stenosis when the pressure rise up to 75, more than 75 millimeter Hg. Mild aortic stenosis may present with exercise intolerance, easy fatigability, and sometimes it could be asymptomatic. But moderate aortic stenosis can present with the chest pain, dyspnea on exertion, dizziness, and syncopal. As it is, as you can see, if during exercise or left ventricular outflow is obstructed, so the availability of blood, oxygenated blood to the systemic circulation is less than normal. So there is these symptoms due to decreased oxygenated blood may cause chest pain, dyspnea on exertion, dizziness, and syncope. Severe aortic stenosis may cause weak pulses or sudden death or sudden heart failure. Coarctation of aorta, it is the narrowing of the aorta at various points, anywhere from transverse arch to the iliac bifurcation. and 50% of the cases of the coarctation of aorta are isolated, while the rest of the 50% cases are like occurs in combination of other congenital heart disorders. Most common cause coarctation of aorta, it occur in bicuspid aortic valves, and there are two types of coarctation of aorta. There is a preductal infantile form and the postductal adult form. Infantile form is fatal, it is not compatible with life, and it early death occurs. While in postductal adult form can be asymptomatic, or it could be symptomatic depending upon the narrowing of the aorta. Male female ratio is 2:1. Male are more predominantly affected, and it account for 7% of all congenital heart disorders. As you can see in the picture, this is the aorta from uh, left ventricle, and there is a narrowing here after these great vessels. Okay, and it is postductal. What other heart anomalies is associated with coarctation? Bicuspid aortic valve, it is seen in more than 70% patients. What genetic syndrome is associated with coarctation? Turner syndromes. Hemodynamic abnormalities, obstruction of left ventricular outflow, increased pressure, and hypertrophy of left ventricle. As there is a outflow obstruction here, there is increased pressure in the left ventricle, but left ventricle has to exert more force to push out the blood, so it's a left ventricular hypertrophy, and in later stages there is a failure. Classical sign of coarctation are decreased or absent femoral pulses. As you can see, when there is blood is pushed out here, the most blood is going into the great vessels, and there is less blood due to narrowing going to the lower limb circulation, so femoral pulses are weak. Higher BP in the upper extremities as compared to the lower extremities. 90% have systolic hypertension of upper extremities. There is a pulse discrepancy between right and left arm. When there is a severe coarctation, there is a hypoperfusion, acidosis, heart failure, and shock. It could be a differential cyanosis if ductus is open. Cardiomegaly is present because of left ventricular hypertrophy, and rib notching can be seen on X-ray. There is systolic ejection murmur can be seen or heard with the stent on left sternal border. This is the on X-ray finding is a rib notching. Hope you can appreciate this, the rib notching of the rib. Treatment, we will not discuss the treatment. Again, there is a cyanotic heart diseases. We have finished the acyanotic heart diseases, stenotic heart diseases, and now comes the cyanotic heart diseases. As in earlier slide, first one or two slide, I told you there are two main defects in cyanotic heart disease: tetralogy of Fallot and transposition of great vessels. For the tetralogy of Fallot, it's a combination of 4 defects. There's a narrowing of pulmonary artery, there's a overriding of aorta, there's a left ventricular hypertrophy, right ventricular hypertrophy. It is the most common cyanotic congenital heart defect, and anatomically there are 4 structural defects which combine and gives the term tetralogy of Fallot. There's a ventricular septal defect, pulmonary stenosis, overriding of aorta, and right ventricular hypertrophy. There's this ventricular septal defect, overriding of aorta. The aorta is arising from left ventricle as well as from the right ventricular. So as the aorta is overriding, so stenosis of the pulmonary artery and the valve, and as there is a more and more pressure on the right ventricle, so there's a thickening of the right ventricular wall. Tetralogy of Fallot is believed to due to the abnormality and septation of the truncus arteriosus into the aorta and pulmonary arteries that occurs in early in gestation, in the third and fourth week of life. The degree of cyanosis depend upon the amount of pulmonary stenosis. If the pulmonary stenosis is less severe, so the blood is going to the pulmonary circulation for oxygenation. But as it is more stenotic, so less blood is going to the pulmonary circulation for oxygenation. So as there is a less oxygenation, so more hypoxia and cyanosis. Initially, infants may be acyanotic, but later on it may lead to cyanosis. Older children, long-standing cyanosis, and surgery. If surgery not done, the patient may have dusky blue skin, gray sclera, engorged blood vessels, and polycythemia, as I told you, and there's a marked clubbing of finger and toes. Treatment could be medical or in late cases surgical repair, and there should be a subacute bacterial endocarditis prophylaxis for this endocarditis. Here comes the transposition of great vessels. As you know, again I am using this notion again, that as you know from your embryological knowledge, that the left aorta arising from the left ventricle, while the pulmonary artery is arising from right ventricle. From blood from the right ventricle goes to the pulmonary circulation for oxygenation and return back into the left atrium and then left ventricle, and from left ventricular it goes to the aorta to the systemic circulation. So the oxygenated blood is provided to the systemic circulation. But here you can see there is a transposition of the great vessels. The vessel is not arising from their normal position. Aorta is arising from the right ventricle and pulmonary artery is arising from left ventricle. So this oxygenated blood is going again into the lungs and coming back to the left atrium, and again from left ventricle to the pulmonary artery, while from systemic circulation blood is coming to the right atrium and then right ventricle, and again it is going to the systemic circulation. So from systemic circulation blood is not going to the lungs for oxygenation, and it is then again and again it's moving into the vicious circle. In the same picture, the right ventricle is communicated to the aorta, and pulmonary artery is oxygenated blood is not available from the heart right side to the coronary arteries and the aorta, unable to go to the lungs for oxygenation. The blood cannot nourish the heart and the body, so the oxygen poor blood is available to the body, and it may lead to cyanosis. In this transposition of great vessel, cyanosis is always present. Then due to hypoxia, there is a clubbing of the finger. Patient is tachypneic. Single S2 sound is heard, usually no murmur, and there is a sign of congestive heart failure in children with transposition of and large ventricular septal defect. Imaging shows characteristic picture, and ECG finding typically show right axis deviation and right ventricular hypertrophy. Chest X-ray reveals increased pulmonary vascularity, and the cardiac shadow is classically an egg on a string created by narrow superior mediastinum. Echocardiography shows transposition of great arteries, site and amount of mixing, any associated lesion, and it is the diagnostic test echocardiography which may shows the transposition of great vessels and mixing of the blood. Thank you. If you have any question, you can ask. Hello, if there is any question. Is there any question? Is there any question?